Hello everyone, I'm Dr. Aishwarya Upase, postgraduate in Ophthalmology. Today I'll be talking about oculomotor nerve, mainly the anatomical aspects. Coming to oculomotor nerve, we have to know the nerve supply mainly. It supplies all the extraocular muscles, namely the levator palpebrae superioris, superior rectus, medial rectus, inferior rectus and inferior oblique. It also supplies intraocular muscles, namely the ciliary muscle and the sphincter pupillae by parasympathetic supply. The specific learning of objectives of this class is like at the end of the session, we should know how to describe the functional components of the nucleus, understand the oculomotor nucleus complex, understand the central connections of the nucleus, outline the anatomical course of the nerve and list out the applied aspects. Oculomotor nerve is entirely motor in function. It supplies all the extraocular muscles except lateral rectus and superior oblique. The intraocular muscles, namely sphincter pupillae and ciliary muscles by parasympathetic supply. The functional components are somatic efferent supplies for the movements of the eyeball, general visceral efferent, that is parasympathetic for accommodation and contraction of the pupil, general somatic efferent, namely proprioceptive impulses from extraocular muscles supplied by efferent component of this nerve. Now coming to this location, it is situated in the midbrain at the level of superior colliculus, in the ventromedial part of the central grey matter that surrounds the cerebral aqueduct. For a better understanding, I have a diagram which you can always refer to. Now this is the midbrain cross section. It is located at the level of the superior colliculus. This is the medial lemniscus, this is the periaqueductal grey matter surrounded by the cerebral aqueduct. This is the oculomotor nerve, this is the Edinger-Westphal nucleus situated just posterior to it, and it crosses over the red nucleus, the crux cerebri and further on. And if you see at this section of the midbrain, this is the temporal lobe, this section is the midbrain, this is the pons and this is the medulla. So here is the superior colliculus and the oculomotor nucleus complex is situated at the level of superior colliculus in the midbrain. It is a longitudinal column of about 10 mm in length. It extends above the level of the floor of the third ventricle and below related to the nucleus of trochlear nerve. Like here, above it is extended at the level of third ventricle and below it is related to the trochlear nucleus. There are two main motor nuclei. Main motor nucleus supplies the somatic motor fibers, which is a general somatic efferent, and there is an accessory parasympathetic nucleus, namely Edinger-Westphal nucleus. Now the main motor nucleus is composed of subnuclei supplying individual muscles. Now, the dorsolateral nucleus supplies the ipsilateral inferior rectus. The intermedial nucleus supplies the ipsilateral inferior oblique. Ventromedial nucleus supplies the ipsilateral medial rectus and paramedial nucleus supplies the contralateral superior rectus, and there is only one caudal central nucleus which supplies both the LPS muscles. In this diagram, this is the caudal central nucleus which supplies the bilateral LPS. This is the medial nucleus which supplies the contralateral superior rectus. This is the intermediate nucleus supplying the inferior oblique, and this is the lateral dorsal which supplies the inferior rectus. Now we should know something known as Daroff's rule. In this rule, this is mainly for the lesions involving the nucleus. Conditions that obligate nuclear involvement are like bilateral third nerve palsy without ptosis, in which bilateral LPS is paired, unilateral third nerve palsy with contralateral superior rectus weakness and bilateral partial ptosis. Conditions that exclude a nuclear lesion are unilateral ptosis, unilateral internal ophthalmoplegia, unilateral external ophthalmoplegia associated with normal contralateral superior rectus function, and conditions that neither exclude nor obligate a nuclear lesion are bilateral total third nerve palsy, bilateral ptosis, bilateral internal ophthalmoplegia and bilateral medial rectus palsy. So we should know that when there is a nuclear involvement, these things should occur. These things never occur, these things may or not occur. Coming to Edinger-Westphal nucleus, it is situated posterior to the main motor nucleus. It sends the preganglionic parasympathetic fibers along the other oculomotor fibers. It has a median and lateral components. Cranial half for the light reflex and caudal half for the accommodation. So this is the oculomotor nucleus, and just posterior to it lies the Edinger-Westphal nucleus. Now coming to the third nerve nuclear lesions, these are really rare. When the entire nucleus lesion is there is ipsilateral third nerve palsy. Now the lesions which involve only the paired medial rectus, that is the ventromedial nucleus, causes wall-eyed bilateral internuclear ophthalmoplegia, that is Webino syndrome, which has defective convergence and adduction. This is a link where you can actually watch the video on how a Webino syndrome looks like. Now coming to the connections of the nucleus is connected to the cerebral cortex through motor cortex through corticonuclear tracts, visual cortex through superior colliculus, and frontal eye fields. So when there is a lesion in the nucleus, all the components of these nucleus, all the components of the cerebral cortex are also affected. It is also connected to nuclei 4th, 6th and 8th nerves through the medial longitudinal bundle, pretectal nucleus of both the sides for light reflex, vertical and torsional gaze centers through medial longitudinal bundle, cerebellum through vestibular nuclei. So when the nucleus is affected, all these things can be affected. Coming to the course and distribution of the third nerve, there is something called fascicular part. Here the efferent fibers pass from the third nerve through the nucleus, through red nucleus and the medial aspect of the cerebral peduncle. They emerge from the midbrain and pass into the interpeduncular space. You can refer to this diagram. The fibers from the third nerve, they cross over the red nucleus through the crux cerebri in between the interpeduncular fossa, and they come down. Now we should always remember this diagram so that you can identify the lesions. So in Benedict syndrome, we have to know the lesion is affecting the lemniscal tract, the red nucleus, the right pyramidal tract and the superior cerebral peduncle. So it causes ipsilateral oculomotor nerve palsy, which causes ptosis, down and out eye, and diplopia. Because the lemniscus tract is affected, so there will be contralateral sensory changes to vibration and proprioception. There is contralateral ataxia, which is due to the effect as it affects the red nucleus. There is contralateral hemiparesis as it affects the right pyramidal tract, because when the fibers passes through the crux cerebri, they go and supply the contralateral skeletal muscles, and it also causes ipsilateral ataxia, which is due to the superior cerebral peduncle lesion. Coming to Weber's syndrome, in this there is ipsilateral oculomotor nerve palsy due to the lesion affecting the oculomotor nucleus. Then there is diplopia and ptosis because of that, and there is contralateral hemiparesis as the right pyramidal motor tract is affected. Here the red nucleus is paired. Coming to North-Nagel syndrome, here the structures involved are third cranial nerve nucleus, the fibers of the superior cerebral peduncle, and the vertical gaze center of the fourth cranial nerve nucleus. So the clinical features are ipsilateral third nerve palsy, contralateral ataxia and tremors due to the lesion over the superior cerebral peduncle, and vertical gaze palsy as the vertical gaze center is also involved. Now coming to the basilar distribution, referring to this diagram, when the oculomotor nerve leaves the midbrain, it emerges as rootlets. They coalesce to form one rounded cord, and then in the subarachnoid space, it passes between the posterior cerebral artery and superior cerebellar artery. So even here in the cross section diagram, when it passes through the red nucleus, through the crux of cerebri, it comes down, and this is the posterior cerebellar artery, which is above the oculomotor nerve, and this is the superior cerebellar artery, which is below the oculomotor nerve. So if there is a aneurysm or lesion over of these two arteries, there can be ipsilateral oculomotor nerve palsy. Coming to applied aspects of the basilar part, frequently the basilar part, which when it is involved in the subarachnoid space at the base of the skull, as it is unaccompanied by any other cranial nerves. So aneurysms of posterior communicating artery, third nerve palsy with involvement of pupil can occur. So and extradural hematoma, like in this picture, there, the tentorial pressure cone causes the herniation of temporal lobe, which goes and compresses on the oculomotor nerve and can cause oculomotor nerve palsy. Coming to the intracavernous part, after the basilar part, it enters into the cavernous sinus by piercing the posterior part of its roof on the lateral side of the posterior clinoid process. It then descends to the lateral wall of the sinus, lies above the trochlear nerve, and in the anterior part of the cavernous sinus, the nerve divides into superior and inferior divisions. Like in this picture, after it passes through the posterior and superior cerebellar arteries, it goes downward and it pierces the dura and it enters the cavernous sinus on the roof of the cavernous sinus in the lateral wall, and then before coming out into the superior orbital fissure, it divides into two nerves and it enters the two divisions and it enters the superior orbital fissure. Looking at the relations in the cavernous sinus, in the lateral wall, beside the oculomotor nerve, there is fourth nerve and first and second divisions of trigeminal nerve. Then it enters the orbit through superior orbital fissure within the annulus of Zen. In between the two divisions, there is nasociliary nerve, and inferior-lateral to the divisions there is abducent nerve. Like in this picture, this is the superior orbital fissure. This is the middle portion of the superior orbital fissure. This is the superior branch of the oculomotor nerve. This is the inferior branch of the oculomotor nerve. In between is the nasociliary nerve, and inferior-lateral to the division is the abducens nerve. In intracavernous part, it is associated with the involvement of 4th, 6th cranial nerves and sometimes first division of trigeminal nerve. We should remember, when there is a lesion in intracavernous part, the pupil is always spared. So the causes can be diabetes, vascular palsy, pituitary apoplexy due to hemorrhage, infarction of a pituitary adenoma with lateral extension into the cavernous sinus, and intracavernous lesions like aneurysms, meningioma, carotid cavernous fistula. Now in the intraorbital part, the superior division ascends on the lateral side of the optic nerve and supplies superior rectus and LPS. Inferior division divides into three branches: nerve to medial rectus, nerve to inferior rectus, nerve to inferior oblique, and the nerve to inferior oblique will also give off the motor route to the ciliary ganglion. So this is the overall diagram where you can see from the midbrain, the oculomotor nerve, it passes through the posterior cerebral and superior cerebellar artery, enters the cavernous sinus, and then enters the superior orbital fissure and comes as two branches. The superior division gives supply to superior rectus and LPS muscle. The inferior division gives supply to medial rectus, inferior oblique, and also the nerve to inferior oblique will give off the motor route to ciliary ganglion. You can always refer this picture in exams for drawing purposes. Now this is the midbrain. This is the oculomotor nerve complex. So after it comes out of the midbrain, it passes through the posterior cerebral artery, superior cerebellar artery, enters the cavernous sinus through its roof in the lateral wall, comes out as two nerves, two divisions, enters the superior orbital fissure, and then the superior division gives supply to LPS, the superior rectus, the inferior division gives to medial rectus, inferior oblique, and the nerve to inferior oblique also gives motor to ciliary ganglion, which in turn supply the ciliary muscles and sphincter pupillae. Now coming to the applied aspects of the intraorbital part, isolated extraocular muscle palsy, that is superior inferior division or both can be affected. There can be ptosis due to paralysis of LPS. There will be deviation, that is down, out, and slightly intorted due to unopposed action of lateral rectus and superior oblique. So muscle paralysis due to, as the medial rectus is affected, there will be adduction deficit. As the superior rectus and inferior oblique are affected, there will be elevation deficit. If the inferior rectus is affected, there will be depression deficit. If the inferior rectus and inferior oblique are affected, there will be no extorsion. There will be fixed and dilated pupillae due to the as it affects the sphincter pupillae, and there will be loss of accommodation as it affects the ciliary muscles. So causes can be orbital tumors, pseudotumors, trauma or vascular diseases. This is one example where a patient presented with unilateral ptosis. On retraction of the eyelid, we can see the down and out eye and fixed and dilated pupil. Now coming to the blood supply of the cranial nerve, third cranial nerve, the pupillomotor fibers are supplied by pile blood vessels and the main trunk is supplied by vasa nervorum. So the importance of knowing this is when a patient comes to you with a third nerve palsy, we should always diagnose it as a basis of pupil is, if we should look for if the pupil is paired or the pupil is affected. So when the pupil is affected, we should always think that there is some kind of aneurysm or compression lesion going on, as this tumor or the compression, whatever the compression is causing, will affect the pile blood vessels, due to which there will be pupillary involvement. In cases like diabetes or hypertension, due to microangiopathy in the vasculature of vasa nervorum, only the main trunk of the cranial nerve will be affected, so the pupils will be spared, they won't be affected. So when a patient comes with a cranial nerve third palsy with pupillary involvement, always refer the patient to the neurosurgeon. And if the patient comes with a third nerve cranial involvement without, like if the pupil is spared, then you have to refer the patient to the physician. Now coming to ciliary ganglion. Ciliary ganglion gives peripheral parasympathetic, it's a peripheral parasympathetic ganglion placed in the course of oculomotor nerve. It lies near the apex of the orbit between the optic nerve and the tendon of lateral rectus muscle. So the roots of the ciliary ganglion, it gives sensory roots from nasociliary nerve, sensory fibers from eyeball, and these fibers do not relay in the ganglion. And the parasympathetic roots, they arise from the nerve to inferior oblique, contains preganglionic fibers, begin in the Edinger-Westphal nucleus. Postganglionic fibers pass through the short ciliary nerves, supply sphincter pupillae and the ciliary muscle. And then there is sympathetic root from branch from internal carotid plexus, contains postganglionic fibers arising in superior cervical ganglion. They do not relay in the ciliary ganglion and they pass out in the short ciliary nerves. And the branches, they give 8 to 10 branches. It divides into 15 to 20 short ciliary nerves, pierce the sclera around the entrance of the optic nerve and contains fibers from all the roots. Looking at this diagram. So this is the sensory root from the nasociliary nerve, which comes from the ophthalmic nerve and trigeminal nerve. They pass through the ciliary ganglion, but they do not relay in the ganglion. This is the parasympathetic root, which comes from the nerve to the inferior oblique muscle from the oculomotor, from the Edinger-Westphal nucleus through the oculomotor nerve. These fibers relay in the ganglion, they go on to supply the constrictor pupillae and ciliary muscle. And this is the sympathetic root, which comes from the T1 spinal cords, spinal nerve, and they relay in the superior cervical ganglion, and these fibers, they form a plexus around the internal carotid artery, and then they go on in the ciliary ganglion, do not relay there and enter the ciliary nerves. Now coming to tonic pupil, damage to the ciliary ganglion causes tonic pupil. The pupil constricts but then stays tonically constricting. This is what is a tonic pupil means. So cause of damage to the ciliary ganglion can be due to autonomic dysfunction, due to diabetes mellitus, chronic alcoholism, sarcoidosis, amyloidosis, Guillain-Barré syndrome, or panretinal photocoagulation, or can be idiopathic. If it is idiopathic, it is always called as Adie's pupil. Otherwise, if you can recognize any other cause, it is always a tonic pupil due to any of these causes. Now coming to Adie's tonic pupil, it is caused by denervation of postganglionic supply of the sphincter pupillae muscle and ciliary muscle. It is usually unilateral, typically affects the healthy young woman. Affected pupil is larger and irregular, light reflex is poor or absent, mostly absent, preserved but slow and tonic near reflex, that this is called as light near dissociation. There is accommodative paresis, that is sector paresis of the iris, which causes vermiform movement of the pupil. There is no ptosis, so full ocular movements will be there. This indicates absence of third nerve palsy, and confirmation can be with low dose pilocarpine. This diagram shows the light reflex. The efferent fibers from the retina to the optic nerve, to the pretectal nucleus to the Edinger-Westphal nucleus, and from the Edinger-Westphal nucleus starts the efferent fibers which go through the oculomotor nerve and then into the ciliary ganglion, and which then supplies the ciliary body and the sphincter pupillae. So when there is a lesion at the level of ciliary ganglion or the postsynaptic fibers, there can be this can cause tonic pupil. Now as we discussed about AD's tonic pupil, there will be anisocoria. The tonic pupil is bigger, more in bright light. Now this is in dim light. You cannot see anisocoria, as in dim light both the pupils are dilated. When there is a bright light, you can see anisocoria in the affected eye. The affected eye has a larger pupil. There will be absence of light reflex, like when a bright light is shown on this side of the eye, the pupils are not constricting, but there will be slow and tonic near reflex. On accommodation, the pupils are slightly constricting, and when and refixation in the distance in dim light, there will be like no isocoria. And when we put 0.25% of pilocarpine in the affected eye, the pupils will constrict, but the normal eye will not constrict. So you can summarize the features of this referring to this notes. Like anisocoria, the tonic pupil is bigger, more in bright light. There will be absent light reaction due to damaged efferent pathway. Preserved accommodation called as light near dissociation due to aberrant regeneration. Sector paresis, that is vermiform movement of the pupil, which can be seen on slit lamp. There will be no ptosis, no limitation of ocular movements. On low dose pilocarpine test, there will be denervation supersensitivity from the upregulation of postsynaptic fibers of parasympathetic pathway, which causes the adic pupil to constrict. You should also know something about Holmes-Adis syndrome, and this is also an idiopathic condition. In this, there is Adis tonic pupil plus absent deep tendon reflexes and orthostatic hypotension. Now summarizing again, the nucleus complex of oculomotor nerve lies in the midbrain at the level of superior colliculus. It comes out as rootlets and it passes from in between the superior cerebellar artery and posterior cerebral artery. It enters the cavernous sinus at the roof and the lateral wall, and it divides into two divisions, and then enters the superior orbital fissure from the middle portion of the superior orbital fissure, and it supplies the LPS, superior rectus, and then the inferior division gives supply to medial rectus, the inferior rectus and the inferior oblique, and the nerve to inferior oblique also gives off motor branches to the ciliary ganglion, which in turn supplies the ciliary muscle and sphincter pupillae. These are my references. Thank you.